Welcome to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I'm your host, Amanda Mixon. Today, we are diving into a topic that continues to challenge many of us in practice: how to manage patients with polymyalgia rheumatica, or PMR, who don't fully respond to glucocorticoids, or those where we've had a difficult time tapering the steroids. Despite steroids being the cornerstone of PMR treatment, a significant number of patients experience relapse or develop steroid-related complications, leaving providers with difficult decisions and patients with persistent symptoms. So what are the options when the standard approach falls short? How do we define refractory PMR, and what do newer therapies have to offer? To help us explore these questions, I'm joined by the incredibly knowledgeable Claudia Rivera Salas. Claudia, thanks so much for being here. As one of our field's rising stars, can you introduce yourself to our listeners who maybe haven't had the chance or good fortune to meet you yet?
Hi, Amanda. I'm so happy to be here and be answering some of the questions today. So my name is Claudia. I'm a nurse practitioner in East Lansing, Michigan. I work at Pine Hollow Partners, which is a nurse practitioner operated rheumatology clinic. So in our office, our mission really is to serve the underserved. So a big part of our patients are Medicaid and Medicare. So they sometimes have to travel hours just to come see us because there aren't any rheumatologists in their area or any providers that will take their insurance. So they come to see us and we take care of them. So we do tend to see some advanced diseases in a lot of our patients because they don't have a lot of access to care. So that's where we all fit in.
It's so incredible that you do this work that obviously is so needed in the community. And remind me how long you've been practicing?
I've been practicing just around 5 years.
5 years. And I can only imagine the things that you have seen. I mean, because unfortunately, when you see patients that are underinsured, unfortunately, a lot of times those patients are much sicker. And so, 5 years is probably 15 to a lot of us because just all of the things that you see on a regular basis.
Right. Absolutely. I'll have patients, we think, patients don't get the deformities in their hands. They don't get that much joint damage and destruction. But by the time they come see me, they do. So I see a lot of deformities in people's hands still, which is sad.
It is. I mean, but again, just I think highlights the work that you guys are doing and how absolutely needed it is. So again, thanks so much for being here. And, I think this podcast is a little bit different than what we've kind of traditionally done in the beginning. We're going to start with something fun. So we're going to talk about a case because I think this will kind of further answer some of those questions that I initially brought up in the beginning. So let's walk through Carol. She's a 73-year-old retired school teacher that was recently diagnosed with polymyalgia rheumatica. So she kind of presented with classic symptoms: the shoulder pain, morning stiffness, elevated sed rate, CRP, difficulty getting out of bed, kind of that classic presentation that we see, in clinic where we say, yep, this is definitely PMR. We've ruled out other things. And she really responded well initially to 15 milligrams of prednisone. But unfortunately, within a few months, our attempts to lower that below 10 milligrams resulted in symptom flare-ups and worsening fatigue. So now we're at 6 months. And Carol is unfortunately experiencing some of the unwanted side effects of steroids, like weight gain, insomnia. Now her sugars have been elevated. So not only are we now unable to get her below 10 milligrams, which after 6 months, that's definitely a problem. But also, again, now she's having some side effects. We really need to kind of think about what we do. So just to start, tell me how you would define refractory PMR in clinical practice. Is it simply just, they can't reduce their steroids, or, what else should we be looking for?
Yeah. So, I would definitely say that I see Carol pretty often. Okay. So Carol definitely has, relapsing symptoms, persistent relapsing symptoms. So the way that we typically define refractory PMR is persistent or relapsing symptoms despite the appropriate steroid therapy. So basically patients that we can't reduce less than 10 milligrams of prednisone, or if we're reducing them and then they flare, so they have to go back up, that is another sign, and prolonged treatment duration as well. Recurrent relapses. So basically, the ones that we can't get off of the steroids, or else they start to flare. I would definitely say other things, the red flags we should watch for, that I'm always watching for my PMR patients, are things that would suggest something like giant cell arteritis. So, for example, we know that 10 to 20% of patients with PMR can develop giant cell arteritis. So I always make sure to ask my patients, okay, any new onset headache, especially, tenderness around the temporal arteries, scalp tenderness, maybe some pain when putting on their glasses or combing your hair, things like that. Pain with chewing, so the jaw claudication, pain with chewing, and of course, visual changes. So blurry vision, of course, if you're having vision loss, you gotta get them into their eye doctor or to the emergency and put them on a higher dose of steroids, because you don't want that to be permanent.
Absolutely. I mean, I couldn't agree more. I think it's so important that we remind ourselves all the time to ask those questions. I mean, I obviously, just like you, do it right from the get-go just to see if it's concomitant GCA, or of course, every single visit, because, people don't automatically think that might be something associated, but it's definitely a conversation I have right at the diagnosis. Like, hey, there are very few rheumatologic emergencies, but this is one of them, because obviously it can lead to vision loss that we can't, usually get back. And so, so important. And yeah, I mean, I would definitely agree with you. I think Carol is definitely a refractory PMR. And I see them too. It's like, we just can't seem to get the dose down. And, I think this is really where we're kind of trying to think maybe about some newer therapies sooner rather than later. I don't know that I would necessarily wait 6 months, but let me ask you this. So what are some common pitfalls or missed considerations when patients like Carol initially respond to steroids, but then relapse during tapering?
So for example, misconsiderations, you want to make sure that it's actually PMR. You got to make sure it's actually polymyalgia rheumatica. Of course, steroids will help a lot of inflammatory diseases. So, you got to check your differentials. There's a few out there. For example, rheumatoid arthritis difference, is that it can mimic PMR when the hips and the shoulders are involved. A lot of times, rheumatoid arthritis will affect the small joints. Okay. And we'll see the swelling, the joint swelling, synovitis, which is not so typical in polymyalgia rheumatica. Other things like fibromyalgia, a lot of times that can also be mistaken sometimes for PMR, or which one is it? But fibromyalgia, you got to remember, it's widespread pain. It's not just proximal. A lot of times these patients will have normal inflammatory markers, which is a big difference compared to PMR. A lot of times younger population, of course, can happen in the elderly, but a lot of times younger, so less than 50. Sleep disturbance is common, fatigue is common, and no response to steroids a lot of the times. Other things, you got to make sure it's not polymyositis or the inflammatory myopathies. So, these patients will have that stiffness as well. But a big difference is that in PMR, there's no weakness, but there is weakness in the myositis. And elevated muscle wasting enzymes like CPK and aldolase will be positive in polymyositis or inflammatory myopathies compared to PMR. And a lot of times these patients, they don't have that fast response to low steroids, okay, compared to PMR, where, the patients, if they have PMR, you put them on some steroids, next day they come and they want to just kiss you because they feel so much better. Other considerations to think about, osteoarthritis, especially, the shoulders, the hips, shoulder conditions like rotator cuff tears, frozen shoulders. So, we think, okay, might be worse with use, not so much morning stiffness like PMR typically does, and a lot of times can be unilateral. So that is another key difference that we would want to think about. Other things, if my patients, for example, if they are not doing well, if I can't get them down, I wonder, is it inadequate treatment, or, are they taking their medicines? What's kind of going on? It is a lot of times difficult for patients. They get this big calendar. We give them a big calendar and we say, okay, from here, start reducing by 1 milligram and then cut down. A lot of times they get confused, or a lot of times they don't do it. And I'm thinking, okay, they're following my plan, but you got to check. Maybe they were doing 5 milligrams instead of 10 milligrams of the prednisone. So you really have to make sure that they're adherent to the medication. Absolutely.
No, it's so true. I mean, and it's interesting how sometimes people will kind of just also do what they want. So like, you tell them like reduce like this, and then they come back and I'm like, wait, why are you on the same dose that you were last time? Like, wait, didn't we talk about this? I mean, I can't begin to tell you how many times I have those conversations. And some of it I think is, sometimes fear that they feel like they're going to get bad again or et cetera. But I totally agree. Like if patients are keep wanting to like increase, and like they're not responding to 20, 25, 30, you probably have the wrong diagnosis. And I think you have to go back to the drawing board and think about some of those other things. The other thing that you mentioned, which I think is a really important teaching tool, is the weakness, because people will come in saying that they're weak. But actually, this is where your physical exam really comes in, because when you actually test their strength, it's normal. So it's like this perception, but actually they really do still have their strength intact. So yeah, I totally agree. I guess the only other thing that I would add is an underlying malignancy, that sometimes those can obviously cause the inflammatory markers to be up. And in an elderly patient, you always have to kind of think about that too. But yeah, I'm with you. Those are all the same things that I think about as well. Certainly with really high markers of inflammation, I'm also thinking of maybe vasculitis, but it'd be kind of rare in an elderly person. But again, aside from like the GCA piece to it, but yeah, I'm kind of I have my brain thinking about other things, and again, that key is that response to the 15 milligrams. So, we kind of already touched on this, but, after 6 months, it is not uncommon for people to start having Pete's, I've had people have side effects after 1 month of being on the steroids. They're bouncing off the walls. They're not sleeping. They're aggravated. They're sweating. I mean, you name it, muscle cramps. I mean, I tell people, yes. I basically say to them, this is the drug that we love and hate all at the same time. Like nothing works as well as it does, but there really are some, things we really have to think about. So, so obviously Carol is showing these signs. At what point do you, in your practice, consider steroid sparing therapies?
So in our practice, we tend to be pretty, I would say, like aggressive. Like we hate steroids. Okay. Steroids are, like you said, like the devil's candy. Like you feel great, but then like they're ruining your body basically. So we really try to reduce the steroid use as quickly as we can. So if I can't get her down, pretty fast, I'm going to get her on something that will help bring her steroid levels down for sure.
Yeah, so you wouldn't have waited 6 months then, it doesn't sound like.
I would not have waited 6 months. Absolutely not. Yeah. I would give her like, I don't know, maybe even half of that. I would probably say if she's not doing great, and I would probably be one to add something pretty fast, which is, what we would probably do with a lot of our other inflammatory diseases is why just stay on steroids? There's other things out there that we can move on to and that they'll work and we can get you off steroids faster. Absolutely. So, at this point, Carol's having the insomnia. She already has that blood sugar, that weight gain. Who knows? She's 73. She's probably higher risk for osteoporosis already. So we don't know how this is messing with her bones either. So I would have definitely start her on a steroid sparing agent.
Well, with that, what agents should we consider for steroid sparing, and how do you kind of determine which one you do?
So there's some evidence for a few of them. So typically the way we start, similar to, rheumatoid arthritis, psoriatic arthritis, a lot of times we'll start with a DMARD. Okay. So there's a lot of good data with methotrexate. Methotrexate is one of the most commonly used steroid sparing agents. So a lot of the clinical studies show the dosage anywhere from like 7.5 milligrams a week to 25 milligrams per week. We tend to just like increase slowly, maybe start them on, 4 methotrexate tablets so we can slow increase, every other week to 6, and then see if we can bring down that steroid from there. Most commonly, the data shows maybe around 15 milligrams per week, of course, with folic acid was effective dose in a lot of the studies. There are other, for example, I saw the podcast where you guys were talking about the leflunomide. So leflunomide is another great steroid-sparing agent. It's a little bit easier, 1 pill once a day. There's also some data with azathioprine. And of course, we have a great biologic that's approved for polymyalgia rheumatica, sarilumab or Kevzara. So I definitely have put patients on sarilumab and to reduce their steroids even faster. So the data also shows that the sarilumab will work faster compared to methotrexate in reducing steroid use.
Yeah, I totally agree. I mean, it's so hard because it's so individual. I was actually, just talking to a younger, newer, well, everyone's kind of younger now and newer than me at this point, but I was talking to someone that's kind of newer to practice and just about how, like, if you ask 10 people, 10 rheumatologists, you're going to potentially get 10 different answers because we all just do things differently. And I think a lot of it's based on our mentors and how, we learned from them. And then we kind of practice, some of what they do and then things we pick up along the way. But those are all the same things that I do as well. But I really, with all this kind of growing evidence with this IL-6 inhibition with PMR, I really feel like that's kind of, I've now really started skipping them. I mean, and I understand cost is always a factor, of course, but I've kind of skipped over like the methotrexates and the leflunomides. Not to say I never do that, but just because I'm like, wow, we have this FDA approved medicine. The thing I really like about sarilumab and just the IL-6s in general is you watch their inflammatory markers like just go to zero, like really, pretty, effectively, efficiently. And so, they just feel so much better, in my experience, pretty early on. So, you kind of already mentioned it, but how do you see these IL-6 inhibitors, sarilumab is kind of the one we have at this point for PMR, fitting into this landscape?
Yeah, I would say I'm definitely with you. In our office, we tend to go pretty fast to the biologics. If we have any issues as far as insurance, we might have to try one. But I don't love methotrexate. I mean, methotrexate is technically a great drug, but most of my patients just can't tolerate it. So, they'll lose their hair. I got to be so careful with fatty liver, alcohol, their kidneys, their liver, everything. So I don't love the DMARDs. They have their place, okay, but I would definitely I'm more of sarilumab. So things to kind of monitor with the sarilumab is you do have to get your labs. Risk of infection, the cost isn't a big issue as well. So you have to have some some insurance or something like that. So I would say we tend to we go pretty fast for the biologics because methotrexate and the DMARDs, they're kind of the old school medicine. So why not try, something that's more targeted? PMR is an IL-6 disease. Why not treat it with an IL-6 kind of thing? So I'm with you. I try to skip over them. If once in a while someone that says, yeah, I'm not ready for an injection or whatever, and we can try some of these other DMARDs, but we tend to go pretty fast to sarilumab.
Yeah. And I feel like it's also, just, you can kind of talk to, for as good as they feel almost initially and how fast you're kind of then able to get off the steroids. It's pretty nice. And kind of patients also understanding like this isn't forever. Because we have to also remember like this is the one of the only diseases that we treat that is sort of self-limiting. Patients don't have to see us forever. So I guess, so you and I are both on the same page in terms of like early biologic use. I feel like that is really like the highlight of everything that we've been talking about lately on RhAPPcast with just various disease processes, because we have now all of these biologics for various diseases that we just didn't before. And so why not treat these patients kind of like we do because rheumatoid arthritis is kind of mainstay. I mean, if they're not responding within 3-6 months, like you're moving on. And now I feel like we're kind of now doing that with lupus. We're doing that now with obviously PMR because no one really wants to be on steroids for long. But obviously there's education that needs to be done, right? All of these drugs have risks that are associated with them. So when you're talking to patients, we're talking about an elderly, typically population and, kind of taking out the insurance piece, because that's obviously could be an entire podcast on its own about like, can you get it? Medicare, all those kinds of things. But, taking that aside, what are some of those shared decision making, that you're having with patients when you're talking to them about this biologic, like discussion on risks, benefits, cost? I mean, what are you saying to patients?
Yeah. So, of course, putting insurance and costs aside, the main thing that I would say is, what is going to be most dangerous for you are the steroids. Honestly, your risk of infection just increases significantly with steroids compared to some of our other medicines, especially our biologics. So I tell them, you're not going to have weight gain with this, this injection. You're not going to have insomnia. It's not going to increase your risk of osteoporosis or anything like that. So I kind of talk to them about the risks and benefits. I tell them, hey, our first priority is really getting you off of the steroids because they're just bad for you. So when I talk to them, I tend to tell them, hey, when I start you on a biologic, it will be one injection every 2 weeks. One injection, belly or thigh. I teach them how to do it. Easy pen. You press the button, goes in super easy. I tell them if you're sick, if you have an infection, don't give yourself your injection. Just wait until you're not sick anymore. Or if you're on antibiotics, don't take it at the same time as your antibiotics. Just wait the next week. We do monitor our patients, so I tell them, I'm going to get your labs. Every time we see you, every 3 months, I just want to make sure nothing weird is going on. There is some data that says maybe checking for neutropenia, thrombocytopenia, but I will say I honestly haven't even seen that in any of my patients, which is good. I would probably say compared to methotrexate, I would see that a lot more often. I would see some lab changes a little bit more often. Methotrexate compared to sarilumab. So those are kind of the things that I tell them. I tell them, sarilumab, I honestly don't tend to see a whole lot of side effects, honestly. It's just kind of like your body is bringing out the inflammation with the injection. Compared to, with methotrexate, I tell them, okay, you might have flu-like symptoms, you might have nausea, you might have diarrhea, these kinds of things. So that's kind of why we also tend to just get onto the biologic boat a little bit faster too. Less side effects, less risks compared to methotrexate compared to also and the prednisone too.
Yeah, for sure. I have a similar conversation with patients too. I think the one additional thing I kind of try to keep in mind, well, I guess two, is checking the cholesterol. So I kind of do a lipid panel, making sure they have that for baseline. It's amazing to me how many people have not had that done in like a very long time. And so I think, oh gosh, but I certainly that's kind of something else. And then I also asked the question about diverticulitis because of this patient population. I always like to make sure because obviously there are bowel perforations that have been reported. And so that's something else I kind of like to make sure of, before we kind of step down this road. And you really have to then really make that shared decision making. What's worse, the steroids, or you have a history of diverticulitis and kind of understanding what the risk profile is. But yeah, I agree. I mean, I've had really good luck with the medication and patients have done well with it and we're able to get the steroids off, sooner in my experience than with some of our traditional DMARDs, leflunomide, methotrexate, azathioprine, et cetera. And so that to me, obviously with steroids, it's not a question of will you have some kind of toxicity or side effect. It's just more when and what is it going to be and how bad is it going to be?
Exactly. Yeah, I'm so with you. When is it going to happen? You're already having these symptoms. What is it doing to your insides kind of thing? Yeah.
Yeah. Well, and so obviously, again, you and I are definitely on the same page. So if Carol were your patient, what would your short and long-term goals be for her care? So, what does success look like for a patient with refractory PMR?
Yeah. So success, I would definitely say looks like no more steroids. Okay. There is a point. The good thing with PMR is that they don't have to see us all the time, kind of like you mentioned. So reducing your steroids and having her under, low symptoms, low side effects, being able to do the things that she wants to do, being able to move and not deal with the stiffness and difficulty moving and all of that.
Yeah, me too. I agree. And I think it's getting them off the steroids and then eventually getting them off all of therapy and just having them, go about their way. I know I actually really, really liked this one gentleman that I took care of, and I got him on sarilumab, got him off steroids fairly quickly. And then I was able to extend out the dose, and then eventually we stopped it, and we had to have a conversation. This was just a couple months ago where I was like, you don't need me anymore. So, I guess call me if you need me. But it was bittersweet, of course, because I want people to be in remission and not need to see us. But, sometimes you really click with people and you're like, dang it, I'm not going to see this person anymore.
Yeah. So I just saw a patient not that long ago too, that, she completely was off of the steroids, and we did the same thing. There's some people say, okay, just stop the sarilumab right away. There's not a lot of good studies that say yes or no, or keep going or wean off kind of thing. But we just stopped it, and she lived happily ever after. So
I know that is the dream. It's totally the dream that we cure our patients, get them into remission, and then they don't need to see us anymore. But we don't have too many diseases like that. Well, thank you so much. I think this has been super helpful. So as I see some of the things you have said is obviously long-term steroids, not good. Really, we should probably be more aggressive and more upfront in our therapy sooner rather than later if patients are not responding like we need to. And also something else I took away is just that we need to definitely be talking to we see our patients regularly, talking to them regularly and monitoring for those toxicities or compliance issues or, their inability to get down on the steroids so that we can move on and get them into remission and limit those steroid toxicities. And, again, hopefully this was helpful to all of our listeners to know that, this is kind of what we're all, this is what we're doing out there. We're really trying to get these patients into remission as quick as we can, kind of that treat to target approach now with PMR instead of just keeping them on the steroids forever and ever. I used to tell patients, the average amount of time is 2 years. But of course, I had those people that were 5 years still on steroids. And I would never do that at this point anymore with the medicines that we have. So that wraps up our episode of RhAPPcast today. So again, a huge thank you to Claudia for sharing her insights and helping us navigate the complexities of refractory PMR. As we continue to see evolving treatment options, it's essential that we stay informed and connected as a community. Claudia, before we close out, is there any last words you'd like to say to our listeners?
What I would end with is saying that steroids are like that helpful neighbor. So you're grateful at first, but by month 6, they've eaten your food, they've wrecked your house, and they've raised your blood sugar. So get off of them. Get off of them as soon as you can.
So you said so steroids are the helpful neighbor, but also the devil's candy. I think I also heard you say.
The best of the worst.
It's so true. Well, thank you again. And hopefully you've enjoyed this conversation, but make sure everyone to please check out our RhAPPACE 2.0 mobile app. It's our central hub for all digital education. And literally there is more education coming week by week. You will find our content room library, message boards to connect and collaborate with your fellow providers, and much more designed to support your clinical practice. Please don't forget to follow us on social media. We are on X and Instagram at RheumaAPP and LinkedIn at Rheumatology Advanced Practice Providers. Thank you for tuning in, and we will see you next time on RhAPPcast.